Sean, hi.
Hi, Dee, how are you?
You're finding yourself?
I'm all right, thank you.
Good.
Yeah.
Shall we begin?
Sure.
Welcome, everyone. Thanks for joining us for another session on Substance Talk. So, we are starting a new series today around mental health. This is our 7th episode, right?
Yep. 7 of us.
Right. So this episode was inspired by one of our colleagues who wanted us to address this. Sean, I don't know, do you know Ntantla?
I've heard of Ntantla from Julie because he did some training with her, but yeah, so hi Ntantla.
Ntantla, just opened your mic so that you just give us some of your experiences and what prompted this question.
Okay, hello guys, hello everyone. My name is Ntantla Mlonyeni. I'm a clinical associate working in Kroonstad, Free State. We have a substance use program. We named it Location Sila, whereby we try to assist patients with substance use. So in short, yeah, so we are working with different organizations and so forth. But in short, one of the questions that I had our post last week is that I have a few clients, it's a male and a female. They are both in their late 20s and they are using multiple drugs, cigarette, tobacco, crystal meth, and cannabis. So they're using all these drugs together from time to time. So the parents and the patient are complaining about having hallucinations and auditory hallucination and visual hallucinations, whereby they believe that those hallucinations are due to them being bewitched. And also the family is also supporting that that narrative that the patient is being bewitched. So that is the case that I'm dealing with, because the patient, I had taken the patient to Bitumelo psychiatric ward, whereby she was diagnosed with psychosis and she was given treatment, but now she refused to take treatment, saying that she's not crazy, or in her words, she's not crazy, and she's been bewitched. So she's gonna look for options whereby someone can help out with the bewitching part, you know. And now the situation is getting worse, whereby they are now becoming violent and having threats. So it's a bit difficult, because now if I have to call the police and take them to psychiatric department by force, is gonna have consequences with the family, because the family also has a belief that the patient might be bewitched. So yeah, I think I said a mouthful.
Excellent. Thanks, Ntantla. Thanks for that. And this is why we're having this whole series dedicated to mental health. I think, Sean, in my few experience while I was working in a hospital, as much as we know about mental health, it's pretty much as much as we don't know. And in that mixture, you add substances, it just becomes more complex. So this series will dedicate a few episodes towards it. I think just to create disruptions, we'll have a few case studies presented. And ultimately, this is a platform for us to engage and share information, not just from our end, but also for us and the rest of the other participants to learn from each other. And I truly hope that you guys will also take the opportunity, as Ntantla did, asking a question and letting us tackle it. So, Sean.
Yes, complex case.
Yeah.
So can I ask a quick question? Is it the two people that you're talking about, is it only the two people, and are they related? Are they from the same family, or are they from different families, or what's the relationship between them?
No, they are from different families. One is a male and the other one is a female. They are both unemployed and staying at home. No, they don't know each other. They don't know each other. They stay in different areas. One stays in Kronstadt, the other one stays in Odendal. So it's two different places, like 50 or 60 k's apart.
Okay. So if we forget about the substances at this stage, is the narrative that people are being bewitched a common narrative and to explain certain behaviors or certain things that happen or misfortunes that happen to people? Is that one of the common narratives that you might hear in amongst the community?
Yes, especially, yeah, let me say it's a common narrative. Apart from just substances, yeah, it's a common narrative, especially amongst the poor that I've met. Amongst the poor, there is a narrative that they are being bewitched.
Oh, okay. So we must remember that things like mental health conditions, psychosis, and that are incredibly contextual. So if you had to go to certain churches, I'm not sure what the title is, but in my mind, some of the prosperity gospel churches where I've been to, and you just had to look at it in isolation. Or if you had to go to a Kundalini yoga type scenario, or you went to a certain faith healing type of scenarios, you would see behavior that in other contexts would be considered floridly psychotic. It would look as if people hold fixed delusions, that they behave in very strange ways. And really, that's a lot about context, about the cultural contexts and what people are used to. Now, often when we can't explain things in any society, we look towards the mystical to try and explain it. So one of the questions I would want to answer and want to look at with these two particular individuals is, have they had any period of abstinence? And if they've had a period of abstinence, has there been a change in the behaviors? Because if you're using methamphetamine, and in particular in combination with cannabis, we know that there's a strong possibility to achieve, to reach a state where you get oral hallucinations. So what that means for most people is they will think that they hear their name being called in the distance. Often they will look, they'll have jerky movements, they will listen a little bit. That is very common with lack of sleep, so sleep deprivation, which often accompanies the use of methamphetamines, but also it's been independently linked with the combination of methamphetamine and cannabis in particular. And that can just stop when the person stops using those particular drugs, sometimes within a couple of days, but certainly about a month or so later. If it continues beyond that, you would start thinking that there's something else underlying it. The paranoia that people get as well is often also fueled by that. And we must remember from a brain point of view, we're talking about adrenaline and dopamine in particular, and moving towards dopamine toxicity, which can create certain types of psychosis. And we look at people who maybe have got Parkinson's symptoms or are suffering from late stage sort of dementias and that kind of thing. One of the medications is to give people an agonist or something that promotes the availability of dopamine between synapses. And occasionally we see people change totally in those stages as well, and develop sort of abnormal behaviors and that kind of thing. Now, similarly, we see that within drug users sometimes. It's not all the time, it's sometimes. But there's a definite distinction between drug-induced psychosis and an underlying ongoing psychosis. And the problem is with the brain is our brain learns new behaviors. And so if people are already vulnerable to that, they can almost learn psychosis, and it can stick around for quite a long while afterwards. And it's very difficult to manage. And I think with your situation, you've got a couple of problems. You've got family members supporting their beliefs. And I suppose in a way, it's not that different to the conceptualization of the demon drug. So for more than a century, we've seen alcohol during the temperance movement. We've seen other drugs described as demons. In fact, the UN language around drug abuse and addiction is that it is an evil. It's the only place in UN documentation that they use the term evil to describe something, not even Holocaust or anything else has been described as evil, but this has been described as evil. So it's not that far off a lot of the common conceptualizations and sort of more Western conceptualizations of drug use, bewitching or to be possessed by the demon drug. The problems with that is it takes the responsibility out of the individual or the system and places it into something which is a kind of impossible target, because how do you cure that? Sometimes we see people's behavior change with in the Christian framework, an exorcism type scenario, in the Catholic framework, in other things by casting out the spirit, or by casting out the demon of alcohol or whatever it was, which they would do, and total abstinence perhaps. It's sounding like to me though that you're not going to win very quickly with total abstinence. So far, does any of what I say make sense? And let's try and find some practical things that you can do.
Yes, it does make sense. I'm just a bit, when we talk about, like, for example, you mentioned the exorcism and so forth. When do we say that, okay, Sharp, this person needs to be admitted? When do we say that this person is a danger to himself and the family or the society? Because, like I was explaining in my case, is that the guy was stopped with he was actually going to stab his girlfriend, who was pregnant at the time. So he was stopped by people in the house, whereby the psychosis made him think that the ladies bewitching him or something like that.
Yeah. And that is the danger of it. Any sort of fixed delusions, in particular with religiosity and religious conviction attached to them, or some belief system like the person can't control their behavior or is unable to control their behavior, or is on a mission to do something which they perceive as essential and good. That's very, very dangerous for both the individual and for other people involved. And in fact, one of the case studies, which we'll look at later, talks quite specifically around those issues. And I've faced that on 2 separate occasions, with where I've been the target of people who have been floridly psychotic and have had prolonged paranoid delusions, and feel threatened by, in this case, myself, or in other cases by other people, and in this case, believing that somebody's bewitched them. So it's very difficult to decide at what point you become more proactive in ensuring that the person gets hospitalized or sent for 72-hour observation at least. And previously you had them admitted for 72-hour observation, and they were found to be psychotic and put on, I would presume, an antipsychotic. How long did that last? How long were they in hospital last time?
It lasted 2 months, because there were follow-ups that she had to attend every month, every first week of the month. But on the second month, she took all her tablets and put them in Vaseline, and told them that she's not going to take those anymore, and she's not going to attend, and she was very violent, if I can put like that. She was very animated, because she was saying that she's not crazy. And I think the week before, she had broken all the windows of where she's staying by throwing stones in the windows. So it was a very difficult situation, to say the least.
And during the time that she was there, did she resolve any of the psychotic symptoms, apart from when she was obviously on the medication? That would have helped a bit. But when she stopped using the drugs, was there some sort of relief from it, or could you not tell because there was medication at the same time?
I could not tell if there had been a major difference because I had visited her. I think we went together to the hospital, and then I visited 2 weeks later, whereby the way we were talking, it seems as if she was still the same. Even the parents did say that they didn't see any change since she was started using medication. But again, there's a belief that she didn't stop using the drugs again because the mother works and she's the oldest one at home. So there's no one to tell her what to do when the mother's not around, you know. So I believe that she still continued with using drugs.
Yeah. So look, these are particularly difficult cases because your natural instinct, it sounds like to me, is to say this person needs more intensive care. They need to be admitted to a psychiatric institution for observation. And it sounds like they definitely need to be medicated to protect themselves and to protect the people around them for both of these individuals. However, if the family believe that this person is bewitched and that the psychiatric facilities are not going to do any help, there's often a belief that the medications themselves are not right and are equivalent of drugs and should be banned. You put yourself in the firing line of the family. However, there is an ethical responsibility, I would argue, to make sure that the person gets the best care that they can within the framework that we've got. I'm not sure if there's been any contact with or how they would see the role of traditional healers in this place. Would there be a role for them to help resolve the bewitching if they see it like that? Because sometimes there's a collaborative effort with a traditional healer and with sort of more Western medical options can achieve some of the goals. I've seen that happen before, but it depends very much on context. And certainly, I wouldn't be the person to say to you, this is what you must do in this particular case, because I don't know the context at all.
They're not really relating to traditional people. They believe in church. They're Christians, if I can put it like that. So they had invited some people to pray for her and her family. And yeah, so they do have a religious support with prayers. But the traditional route, they had not ventured into getting that's the girl, ne? The guy and I did go and consult with the traditional healer, and she was told to go and wash in a river where there's flowing water. That will help, and it didn't.
But you know what's very interesting is that in Roman times, and the washing of water was commonly prescribed to people to go and sit in the warm baths around Italy and Rome and that. What's really interesting is they were very high in lithium, and lithium is an antipsychotic. And so people would literally go and sit in these warm baths for ages and become unpsychotic, resolve their psychosis. And that today we use lithium actually to do the same. So it's a pity that the river isn't rich in lithium, because that actually could help. It seems crazy, but that's where a lot of our medicine comes from traditional sources. Look, in your particular situation, I think that if and we must get suggestions from anybody else who's listening in at the moment, because hopefully others, certainly others will come across this kind of problem in the future, if not in the past. But I think that at some stage, in particular, if the violence escalates, if the person becomes a danger to themselves, you at the very least need to notify the psychiatric hospital of this, and because there will be a file for them there, and consider involving an admission that is sort of not voluntary, a non-voluntary admission. But obviously that's difficult to enforce, especially when the family are not favorable of it. And often police are not trained to handle these kinds of things and could cause a lot of problems as well. So the other option is to engage with the families and to say, well, look, these symptoms aren't resolving after the prayer sessions and after the traditional healer in the case. There, you know, and look, I mean, how you frame it can be really important. And also it depends on the belief system of the people. Do they believe that, you know, there's some Christian groups that believe that medicine itself is not acceptable, whereas others frame medical interventions as a gift from God as well. So it depends on how they frame it. But one would hope that before the situation becomes too violent, it becomes clear that they're going to need some external help. And the way I would do that with people is to use the principles of motivational interviewing with the family and empathize with their situation, repeat what they're saying to you very carefully so that they know that you've listened and heard and understood them. And then, and we can actually discuss this in the next session if people are interested in it. There's a way of what you do is you then ask them, what do you believe would help this particular individual? And how much do you believe that on a scale of 1 to 10? And why a 7? Why not a 3? Why not a 4? And that gives you the opportunity to introduce new ideas and options and for people to critically examine their own thinking. And, you know, because facts very seldom move people. You need to link with their kind of ideas. But it sounds like to me, without the family's buy-in, you're really going to have a problem in getting these people admitted unless it's an involuntary admission. And really all I'm doing is repeating what you already know. So I'm not sure that any of this is helpful.
Yeah. So the thing is, the family believes that if the child will go to rehab, that will help, you know. But now the problem with the rehab this side is that currently there's only one facility that offers rehab services in Free State. It's the one in Botshabelo, it's the psychiatric complex in Botshabelo, which offers for free. But now the problem is that it's just always full. Like if you need to make an appointment, you can be, you know, delayed by up to 6 months, whereby you have to wait for your chance to go there for like for 21 days. Yeah. So that's the issue. And then if they have to take them to a paying facility, they do not have the means to take her to a paying facility. So that's the other issue that, you know, they would love for her to go to rehab, but now there are no available options.
So here's the way of framing it, because the fact is that when families start saying we would like somebody to go to rehab, 9 times out of 10, what they're really saying is that we're not coping and we would like this person to go somewhere else. That is what they're saying, but we want to be compassionate about it. And most of the time, that's what people are saying, really, when they talk about rehab, because we know that the majority of rehab attempts do nothing more than maybe give a temporary solution, or for some people, for a minority of people, what happens is they were ready to make the change and they just need a little bit of space out of their community and that to make that change. And if they're fortunate and get the right support structures when they come back, some of them will get better. But then what would happen is the person would have actually probably resolved it if they had gone to an ongoing outpatient program or got the support. Most rehabs do not make people resolve their drug use issues any faster than they would have with support in a community-based setting. And in fact, some of them cause a lot of damage because they tell people that they're always an addict, that they need to abstain from all mind-altering substances, and if they relapse even once, they might as well give up and that. So that kind of non-change talk is not helpful for some people, and also it introduces people to new drugs as well very often. So rehab can be good for some people, but it's certainly not the answer. Now, if you can frame the psychiatric facility as a form of rehab, so for example, frame it as a dual diagnosis unit with a rehabilitation component to it, and secure them a longer term admission for inpatient for maybe 3 weeks or something like that. And I don't know what the facilities are like there. I know that in Cape Town, there's usually some waiting lists around prolonged admissions. The acute ward at Groote gets filled very quickly, and then they have to move people through or move them into Valkenburg here in Cape Town. But if you've got that opportunity of reframing it as maybe a dual diagnosis unit or as a form of rehab, that may help. But if they've got their mindset on rehab, the way you frame the hospitalization may assist that process. I know that you don't want to be manipulative, but at the same time, you also want to make sure the person gets the help that they need. And this sounds way more like a mental health issue than just a drug issue to me at this stage. That would be my initial thing, not to diagnose. Yeah.
Okay.
And I think that's the complexity with mental health and substance use. What do you prioritize? Should we even prioritize? And I'm just thinking around the concept of bewitching. There was a whole story about a whole congregation drinking petrol to show, and that's danger to self. How far do we say that this is, because that doesn't present in a psychotic state? And how do we rationalize these processes, the dynamics of it? And I wonder that your client, when you met them, were they in a psychotic state or not? Were they in a position where you can have a constructive conversation with them?
Yes, they were not in a psychotic stage, ne? We could have a conversation, but their speech was full of delusions. They were a little bit delusional in what they were saying, they were observing. Because what they were saying, they're observing, other people could not observe. So, but you could talk to them and have an intellectual conversation. It's just that the delusions that they present when they talk.
So what sort of delusions were they presenting, particularly around the bewitchment or that kind of thing?
Yes, like for example, they would say that there are people at the back of the house who are talking about her, and they're plotting to kill her. She can hear them at night as they are talking, and they are following her everywhere. And their parents can hear also those. But as she says that the parents hear those things, but the parents, when they talk to them, they say they don't hear anything.
Yeah.
So it is that religion, if I can call it that.
So just for the sake of other cases and that, and for people listening, one of the things that you've got to be very careful of, and the parents are possibly unintentionally doing this, is supporting the delusion. So it doesn't, you can't be confrontational about it, but the language to kind of use with somebody who hears their name being called constantly or thinks people are plotting about them is to say something like, I understand that must be very concerning for you and very stressful for you. I'm not hearing that, but I'm not saying that you're not hearing that. But and trying to keep the person present and grounded a little bit in reality. Parents or people close to them will often, out of frustration or just wanting to keep the peace, will say, yeah, I'm sure they are, but don't worry about it, which is a slightly different way of phrasing things. And that then helps build the delusion and maintain the delusion within the individual. The one advantage with psychosis that's the result of substance use is usually you get gaps where the delusions disappear, and you can actually then talk to the person about, look, this is what happens when you use the substances. Are you aware of this? Are you aware of that? But in this case, where a person has fixed delusions over a period of time, whether they are or aren't using substances, it becomes very difficult to find those gaps of sort of lucidity and congruent thinking that you can work with, which can often then help the person in the psychotic state itself, because it's kind of almost pre-training them to expect certain things and to understand that that's part of the process. And they can then not react as badly to those particular events. Your I'm concerned about what you're telling me because I've seen several cases like this in the past, and the person that normally gets hurt is the actual individual. At one stage, we saw a couple of people suicide because they believed that people were plotting against them. There've been cases where people have self-harmed themselves to try and preempt being harmed by other people, and that. So I'd be very concerned for the individual person as these delusions mount and become more fixed and more in need of action by them. Of course, there is some risk to the other people involved because they could then take preemptive action against them, like the example of the guy you were talking about who went to go and stab his girlfriend. So from what I'm hearing here, I think the priority would be some form of extended stay in a psychiatric institution, especially if they're not taking their medications at all. But I would essentially work with the family on that, and also maybe get one of the, and this is difficult because people don't have availability, but try and get the family to speak to a psychiatrist about it. But again, you get the wrong psychiatrist, that can really put the family off. I've seen that as well. But yeah, without actually speaking to the people involved, it's very difficult to give very direct advice on any of this. All I can say is with mental health issues, always look at the symptoms rather than the diagnosis, because diagnoses are really just a form of labeling a cluster of symptoms when it comes to psychiatric illness. So for example, schizophrenia is a cluster of a possible 108 or 107 different symptoms that can cluster together to be called schizophrenia. And one schizophrenia is not the same as another schizophrenia. And certainly I would say that this person is to some degree would fall under those kind of categories, but it's not essential to label them. What's essential is to try and get the psychosis settled and the delusions resolved, or to have them in a safe space. And both of the cases that you're talking about. And as I say, we have no answers, really. All we can do is help to have discussions.
And now, when do we say that, what do we say for harm reduction? Do we say just, reduce the smoking or stop for harm reduction to take effect? What would you suggest for these patients?
Okay, so, and I'm not sure how much methamphetamine they're using and how much cannabis they're using. There was a very strong analysis done in Australia a while back on the relationship between cannabis in combination with methamphetamine and the number of people that will experience psychotic symptoms. And certainly dose is one of the major issues around it. So what we would do is encourage people not to mix drugs, try and find out if they can reduce their dose. And the way I usually do that with people with methamphetamine is to explain to them that you get a peak level of dopamine in the body, and that is it doesn't get any better after that point. So you get a certain point where you're feeling very alert, you're feeling awake, your dopamine is running optimally for you, you feel fantastic, and that, but beyond that point, everything that happens is not good, and it's just wasting money essentially. So normally what we do is we speak to people about that and try and encourage them to use the minimum possible dose of whatever they're using. My problem in this particular case is I would assume, and I'm pretty sure you'll find that they're not necessarily using a lot of the methamphetamine. They might be using quite a bit of cannabis, and often cannabis is used by people who've got psychotic symptoms to try and still it, because you've got two conflictory things in cannabis. You've got the THC and the CBD, and the CBD is protective actually against psychosis, and the THC can be causative. Well, I don't want to say causative, but certainly can mediate the levels, the potential for psychosis. So you've got this kind of conflictory kind of thing of self-medication and causing self-harm in that. So certainly what we would do is encourage them to try not to mix cannabis and methamphetamine at the same time, and then also to reduce their dose of methamphetamine as much as possible, and then reduce the amount of cannabis that they're using in each chance if they can't stop. Probably you'll find that for some people, the methamphetamine is easier to stop than the cannabis, is what I found in my experience. There's no firm data around that, but that's been my experience. But for some people, it's vice versa. The nicotine, the factor about nicotine is that it can actually slow down some of the metabolism of certain drugs. So for example, if a person is smoking cigarettes, not vaping, smoking cigarettes, the doses of antipsychotics have to be significantly higher to them, which is interesting. I was reading a case study about this yesterday. And when they come off the smoking cigarettes, what happens is the antipsychotics suddenly really kick in and they become lethargic and falling asleep and put on huge amounts of weight and that kind of thing, and often go back to the cigarettes because of that, whereas you need to watch the dose adjustment for that case. But we don't have to worry about that here because these people aren't using any antipsychotics at this stage. But certainly I would try and encourage them to use the minimum amounts of drugs possible and to avoid drug mixing as much as possible, especially if alcohol comes into that mix as well.
Okay. Thank you very much, Mr. Sean.
Thanks, Ntantla. And I think, because we're on our last 5 minutes, but Sean, when this concept of self-medicating, where clients are using substances as street drugs, and they're self-medicating, because honestly, Ntantla's case seems more of a psychiatric issue rather than a substance-induced psychosis. Yeah. How does one approach that?
Yeah, so Kansian was the guy that first put forward the idea that people self-medicate. There's been studies that have both proven it and disproven it. And so sort of the fact is, so the studies that disprove it tend to say people who use specific drugs for specific purposes, as soon as that drug's not available, they'll use another drug. Okay, so it can't be self-medication. I think that's a false argument because they have a preferred drug, but the drug isn't just about the drug itself and the drug effect. It's about being part of the drug using community. It's about feeling something, and a lot of the drugs will impact your dopamine levels. Some of them will impact your serotonin levels, and so even though you get very different effects from, say, MDMA and from methamphetamine, both of them will have some impact on the dopamine system, and people will ease the pain of withdrawal from methamphetamine. And when I say the pain of withdrawal, I'm talking about a psychological kind of pain, because you don't have the same withdrawals as you would with heroin, for example. They will then use something else to moderate those kind of feelings of anhedonia that they've got and lift their mood a little bit. So when you've got people who self-medicating, look for the underlying conditions. So people with ADHD will often self-medicate with methamphetamine or with amphetamines or with cocaine. People who've got major depressive disorders will move towards things that make them feel warm and comfortable, like the niope stroke heroin, the same thing, niope heroin, or benzodiazepines if they can get access to them through a script, or cannabis, for example, as well. Alcohol is also, in the short term, a good mood stabilizer, but in the long term, pretty destructive. And some of these drugs have very different effects at different levels. So alcohol can be both a sedative and a stimulant. Nicotine is a stimulant as well, So I think when we come to self-medication, which we will talk about later, we must be aware that we need to treat the underlying psychiatric condition. And typically with drug use, there's either an underlying social condition, psychological condition, or psychiatric condition that makes drug use really important and helps people prioritize drug use as a form of short-term survival.
Absolutely. And this is what the series would cover. It would cover different conditions, co-occurring conditions, they name it, with substance use, how to approach a psychotic episode versus how the guidelines to how to approach like a case that Ntantla is dealing with. And I think this is the thing about mental health in itself. It forces us in our different disciplines to work together, because in these situations, you need the different disciplines. And I like to encourage even our viewers that on our website, post some suggestions towards Nhlanhla on how to deal this. This is an opportunity for us to function as a multidisciplinary team to address these issues, because I know I've dealt with similar cases so many times, and they've always left me feeling so perplexed on how to address it, to even approach it. So I really like to encourage everyone to join us on our next series where we will deal with specific approaches. Yeah. Sean, any last message?
Yes, so I'm certainly going to take this further, this conversation. I'm going to speak to some colleagues of mine and probably bring one or two of them on at various stages, and maybe we can get some further information. If Nhlanhla could please keep us updated as well, that would be very useful. And I think the utility of these sessions will develop if we could use them almost as a form of information sharing and mutual learning. These are very difficult issues. And when I start seeing things like 20% of all Americans suffer from a diagnosable psychiatric disorder at any one time, I'm beginning to wonder if we're not pathologizing normality or narrowing our idea of what normal is. And so these things, you know, when I look at things like open dialogue forms of treatment, which don't use medication to a large degree, I wonder how, if we changed our systems and our society, we would start seeing less psychiatric issues. But that's for later discussions and more philosophical. Right now, let's keep it practical. Go out there, be safe this week, and I hope that you survive the week and you know, don't have too many scenarios like this, and are able to navigate difficult seas.
Yeah, no, thank you, everyone. Our next session will be on the 28th of September. And again, we're always looking forward to hearing from you and comments, suggestion, and please, let's help out Nhlanhla as he deals with this very common case. Thank you, everyone. Enjoy the rest of your day.
Thanks, and Nhlanhla in particular. Thanks.
Thank you, guys.